Good morning, everybody. Stanley, thank you, and Nelson, thank you, and really to thank all of you for having me here. And what I'm going to do is I'm going to speak for about 35 minutes, and then we'll have a lot of time for Q&A, where I hope that all the things I should have said but didn't will come out, and we'll have a conversation based on wherever you all want to go. And when I got asked to come give this talk, I think it was the fastest response I've had to a request, and it was a resounding yes, really for two reasons. One is I love Toronto. I grew up in Toronto, grew up not far from here. My parents were grad students at U of T. I lived at 30 Charles Street in that building that looks exactly like it did 30 years ago. No comment. But the second is this institute. And at a time when the world wants to move on, and I'll talk more about that in a bit, this institute is demonstrating leadership, saying we can't move on, that we are entering a time period where the work of this institute is as important as ever. And years ago, 5-7 years ago, before this pandemic, I often used to talk about that we were entering an age of pandemics. Sounded very scary. But I want to take a minute to talk about why I think we're entering an age of pandemics. Why the work of this institute is important now and will be more and more important as the years go along. So if you ask, like, what causes pandemics, right? Pandemics have been around as long as humans have been around. And what causes pandemics is usually novel infections, a new virus, a new agent of some kind to which we don't have immunity. And it spreads rapidly in a population. And there's a whole set of factors that drive something becoming a pandemic. And if you look at what's been happening to the human species over the last 50 years, you get a sense that we've entered a new era. The number of novel infections that are showing up in humans has been increasing over the last 30 years. You're like, well, why is that? A vast majority of novel infections come from animals. They're usually species jumps. That is not my way of saying that's what happened with SARS-CoV-2. That's been very controversial. I'm happy to talk about that if you want. But that's how most novel infections happen. They happen when there's an animal to human jump. And given what is happening in our world, deforestation, broad environmental changes, economic development, humans are encountering animals at a pace much different than we ever have in the history of our species. But a couple other things are happening as well. We've got that. And then on top of that, we've got climate change. And that means habitats are changing, vectors are changing. And then we have globalization. Globalization means that things that used to be local become global very quickly. And I'm reminded of the fact that we're talking about SARS-CoV-2 as the latest pandemic. There was a SARS-CoV-1, all of you know that well. I mean, some of the younger people in the room may not remember it, but Toronto was a center for SARS, the original SARS outbreak. In 2003, if you compare travel within and outside of China from 2003 to 2019, domestic travel in China between 2003 and 2019 increased about 20-fold, and global travel increased about 35-fold. So it's interesting to think, what would a SARS outbreak have looked like, SARS-1, if it had happened in 2019? Maybe it wouldn't have been quite the global pandemic we saw with SARS-2, but it would have been much bigger. And that globalization has happened in China. It's happened in India. It is rapidly happening on the African continent. And my view is that's a good thing, by the way. It's economic development. It's the world becoming more interconnected. There's a lot of benefits. I want to live in a world that's very interconnected. But the downside of that is that local outbreaks become global outbreaks very quickly. So that is the age in which we are. It is the age of pandemics. And I think we have to just come to reality with that, or come to terms with that. Now, the second thing that people often bring up and think about is, well, can we predict pandemics? Can we predict when it's going to happen? And there are a lot of models out there. And when I was at the White House, we'd often have companies saying, we think we can predict the next pandemic. Great. I don't know how to predict the next pandemic, honestly. Like, the number of factors that have to come together is very, very, very hard to build a prediction model that says the next pandemic will be, we can make guesses. My best guess is the next pandemic will be an influenza pandemic, maybe arising from certain regions of the world. By the way, that was my prediction 5 years ago. 5 years ago, I would not have said the next pandemic will be a coronavirus pandemic. So predictions are hard. And so the way I have come to think about the moment we are in is can't prevent these things, given that we're going to have more environmental change, that climate change is here, that globalization is going to continue. And you can't predict these things. So what can you do? And what you can do is prepare. And what you can do, and what we all need to do, is be ready as these things come and be far more effective in our response. And if we do that, I think we can manage our way through the era that we are entering. So what I want to do for the next 10 minutes or so is talk about managing a pandemic. And, look, the last 4 years, you can look around the world, you can look at Canada, you can look at the US, the European countries, Asian countries. I'm not going to list all the countries in the world, but you get the point. There are lots of lessons to be learned. Lots of places did them differently. And I will share with you my sort of high level how to think about managing a pandemic, what the lessons learned are. Your views may differ. And I am on these things pretty simple and straightforward. And so when I think about responding to a pandemic, I think there are two phases. Say they're like, people like to break it down in lots of phases. I'm a simple person, 2 phases. Phase 1, when you largely don't have medical countermeasures. Phase 2, when you do have medical countermeasures. I'll explain all this, what I mean by all this in a second. So if we go back to asking why are pandemics bad, right? We have lots of viruses out there. We encounter them all the time. Why was SARS-CoV-2 so bad? Fundamentally, it's bad because we don't have immunity. We have a whole population totally susceptible to a virus, and we have no immunity. That is the kind of hallmark of a dangerous situation for the human population. So at a high level, my view is the response to a pandemic is gotta be save lives, keep people well, until you can build up immunity safely. And the safest way to build up immunity is through vaccines. Infections also build up immunity, but infections have lots and lots of downsides. The safest way to build up immunity is vaccines. And so obviously there's lots of other things to medical countermeasures like treatments, et cetera. But I want to talk about, in some ways, splitting our response between when you don't have vaccines and when you do have vaccines. Now, there are others, there's still people who believe that the primary strategy of a pandemic, it should be an elimination strategy. That you encounter the virus and you try to eliminate it, just get rid of it. It depends a bit on the virus, but I think for a respiratory virus, certainly like SARS-CoV-2, that was always extraordinarily hard. I don't personally believe it was ever doable, but at some point it became obvious that it was not going to be done. And so we find ourselves saying, if we're going to have to live with this virus, how do we do it in a way that protects people as well as possible? And by the way, some of you may disagree with that and think elimination is possible, and maybe we can talk about that in our conversation. That's just, as I said, my assessment 4 years later, but it is not written in stone. Okay, so what's the strategy during the period of time when you don't have medical countermeasures? Here, my view over the last few years has been that essentially what you're trying to do in many ways is buy time and protect lives while you're waiting, in some ways, for the science to catch up. And I'm going to talk about this a little bit from an American perspective. It's what I know. In my view, there are sort of 2 or 3 things that are really critical in that phase when you don't have vaccines. And therefore, there's no safe way to build up immunity, right? Number 1 is surveillance. I have said publicly, privately, in Congress, elsewhere, that the original sin of the American pandemic response was the lack of a surveillance system. And let me take a minute to explain what I mean, and it'll be interesting to see to what extent you think that applies here in Ontario or in Canada more broadly. We had no surveillance system in the United States that was at all functional. And so when this virus started spreading between mid-January, and maybe it started before then, I don't know, but when it started spreading between mid-January of 2020 and really early to mid-March, when it became clear that it was a huge problem, for 2 months we were blind to the spread of this virus. And then the response that came from states, from President Trump, was essentially a national shutdown, national lockdown. We can talk about, was it a real lockdown? Should it have been a harder lockdown? Should it have been a longer lockdown? Those are perfectly good things to talk about, but that's what it was. And in my view, that sowed the seeds of distrust in the following way. We could all see the refrigerator trucks parked outside of Elmhurst Hospital in New York City. The hospital was overwhelmed. People were dying in extraordinary numbers. And a lockdown in New York City made a ton of sense. The problem was there was no virus circulating in Mississippi or Montana at that time. And so when you lock down Montana or Mississippi, people walked around saying, there's nobody in the hospital. I don't know anybody who's got this infection. And we all understood why we did it. But it certainly created the atmosphere where people were susceptible to the narrative, this is all fake, this is all made up as a way to take away your freedoms. And what would have been way more effective if we had had surveillance was much more targeted efforts. We probably should have been harder in New York earlier, but could have been lighter in Montana. But that would have required us to actually know that there was not a lot of virus circulating in Montana. And we didn't have that surveillance system. So the lack of surveillance system means that your NPIs, as we talk about them, non-pharmaceutical interventions, are always going to be blunt. And that's costly. So a surveillance system is pretty critical. I think we've made progress there, and I can talk more about that and we can discuss this. The second part of the response when you don't have vaccines and other medical countermeasures is communication. So in public health, we have often thought about science communication as a nice to have. Like you figure out the science, you figure out the policy, you go implement it. Oh yeah, by the way, you also want to try to communicate it to people. It turns out that's a terrible way to think about it. It's backwards. And that communication with the public in a public health crisis is got to be job one. So you've got to be able to explain to people what you know and don't know, what you're asking them to do and why, and for how long, and communicating in a crisis where you don't know all the information has its own set of challenges. I think none of us got it right. Certainly I didn't get it right. But I think more communication is better. And the problem that we have as scientists is scientists like to be pretty sure about things before they go out and tell people. And that creates an information vacuum in a crisis. And there are lots of people who are happy to fill information vacuums. And so the second lesson is, so one is surveillance. Second is, got to communicate early, got to communicate often. You got to flood the zone with the best information you have, because there is a massive demand for information in a crisis. People are hungry for information. And I think we did not meet that demand. Certainly in the United States, we as a collective, what do I mean? The government, well, the government at times was also sharing what I thought was really bad information. We had a president who didn't always follow the scientific evidence in a way that I wish he had. So we did not flood the zone with good information, the best information we had. And that created a space for a lot of other people to fill it with bad information. So that's a really critical part of the response. And then I've sort of talked about the importance of NPI's targeted restrictions on mass gatherings, mask wearing. We'll talk about indoor air quality, which I loved. I walked in and saw these boxes, and but ventilation for a respiratory virus. Those are all really critical things. Some of them continue past the arrival of vaccines, but they were particularly critical in the pre-vaccine phase. And the last point I'll make, and then I want to talk about vaccines in a second, is you're not just waiting for vaccines to arrive. You're also waiting for us to learn more about the virus. And here's an interesting fact. My best assessment is that between March of 2020 and October of 2020, so both time periods before vaccines became available, remember, if you walked into a hospital in Boston or Toronto with COVID, your chances of dying were probably cut by 50% between March and October. That is remarkable. 50% reduction in mortality in a period of about 5 months. How? We learned stuff. We learned who really needs a ventilator, who doesn't. We learned that steroids are actually quite useful. We just learned how to manage these patients better. And that 5 months, even well before vaccines arrived, meant that a lot more people survived. So in the beginning, when you know very little about a virus, you've got to do everything you can to give the scientific, the medical, the public health community time to catch up. And so that's why I was pretty, in my public messaging, pretty tough about really being aggressive in that time period. Okay. I want to move now towards, and again, I'm happy to talk about any of this stuff in the Q&A, but I want to talk a little bit about vaccines and what we need to do if we are indeed entering an age of pandemics, what we need to do to make sure that we're better, more effective at building vaccines. So as many of you know, and I've said this certainly publicly many times, we got lucky with the vaccine for SARS-CoV-2. We got extraordinarily lucky. The reason I say we got lucky is SARS-CoV-1 had taught us a lot about how to build a vaccine against SARS-1. We knew about the spike protein. We knew you had to target the spike protein. We had done a lot of work. So when SARS-2 showed up, everybody was like, oh yeah, target the spike protein. And it was not, I mean, I don't mean to minimize the amount of work that went into it, but it was a way easier job than if we did not know that. And so I think we have to assume that the next pandemic will come from a virus where we're not lucky. Certainly being lucky can't be your strategy. Like, let's hope we're lucky again. Sure. But that can't possibly be our strategy. So we need sort of a multiple part approach. And this is a lot of what I try to push us as a US government to do. There are viruses where we have vaccines where we think there's a good chance that they could cause problems. And so building and stockpiling vaccines is a really important part of the strategy. In some ways, that's the easiest part, if you know the virus. So we've done that, by the way, for H5N1, avian flu. We have a stockpile of vaccine kind of bulk material for about 250 million doses. Like it's frozen somewhere. And it would take some time to thaw it and finish and fill and finish it. But we have that, and we should do that kind of stuff. We had that for smallpox and have that for smallpox. It allowed us to have vaccines for Mpox when that broke out because we had that stockpile. So having stockpiles is really important. But stockpiles only work for viruses you know about. What about vaccines for other things? So one of the things WHO has done is created something called the priority pathogen list. Should know the number offhand. I want to say it's like 16 or 18 families of viruses, but ones that we think are most likely to cause the next pandemic. Nipah and Lassa fever and obviously influenza viruses and MERS and other coronaviruses. The idea is, while we could get unlucky and it could be something totally novel, chances are that we can guess at what it's likely to be. And we should start working on building vaccines for those things now. We don't have vaccines against a lot of those things. Ebola, we now have a vaccine. Good, we should have a nice stockpile of that. So we've got to do that work with those priority pathogens. The hardest one is how to prepare for a virus that we know nothing about. People often talk about this as disease X, right? The virus that looks like nothing we've dealt with. And here, there is some really important work happening inside the US government, in some labs, really trying to figure out how can you build a vaccine against a virus that you largely don't understand. It's an extraordinarily hard thing, but there has been progress at figuring out what is creating pathogenicity, what is creating an effective immune response, and then how can you quickly identify those things, and then how can you build a vaccine against those things. So my point here is we've got to do a lot of investments in the science behind vaccine development if we're going to have a fighting chance against a virus that we're not lucky against. Okay. Moving on to, let's say we get lucky, or let's say we build vaccines quickly. Let's talk a little bit about delivery of vaccines and what we learned in the US. It's interesting watching Canada, watching the UK, watching the differences in health systems and recognizing that the ability to get vaccines into arms is so dependent on the underlying health system and the structure of the health system in which you practice and in which you live. For us, we had no adult vaccine program. It's interesting, when the Trump administration left office in January of 2021, Operation Warp Speed had been a huge success. And it's interesting, when I was in the Biden White House, people didn't love it when I talked about how great Operation Warp Speed was. Operation Warp Speed was awesome. And as you may be able to guess, I'm not a huge fan of the former president, but you got to give credit where it's due. What Operation Warp Speed accomplished was extraordinary. Public-private partnership, huge role for academia, huge role for scientists around the world. They got the vaccines across the finish line, but when the Biden team showed up, they found themselves with two problems: not a lot of vaccines and zero plan for getting them into people's arms. Right? The plan inside the Trump administration had been build some vaccines, send it to states, and let the states figure it out, which is really not much of a plan. So one of the things that the Biden team did early that I continued working on, that we all should be thinking about, is what is our delivery mechanism? And I don't just mean like who's going to give the shot, though that's important. But how are you going to create the demand for it? How are you going to build the trust for it? Who are you going to work with? How is this actually going to happen? And I would argue, watching from a distance, that there's a lot of stuff that happened here in Ontario and across Canada that are really good lessons for all of us to follow. And I'll try to distill a few things I've learned both from the US and from elsewhere. So one of the key things has been about partnerships. We in the US, as I said, we don't have an adult vaccine program. To the extent that adults get vaccinated for anything, it's just influenza, and then it's like less than half of the adults get vaccinated. And some of them get it at CVS or Walgreens, right, our big pharmacy chains, and some of them get it in doctor's offices. And it takes about 6 months to get about half of adults vaccinated. And we all recognize that was way too slow. So what the Biden administration did was build a whole bunch of vaccination sites. And in the early days, there were long lines, the people who really, really wanted them. And quickly realized that the demand for vaccines was actually a lot more shallow than I think most people had thought. So the Hunger Games of trying to get vaccines in the first month or two, by month 3, the lines were gone. People were giving out lottery tickets, trying to incentivize people. What really worked was partnering with community-based organizations, religious organizations, people who actually understood the communities in which they worked. And partnership, and I learned this in a lot of the things that we did when I was in that role, partnership is not going to a community-based organization or a religious organization and saying, hey, we need this done, can you do it? Turns out like that doesn't really work. Partnership is about bringing people along, sitting down, saying what are the things you're seeing, what are the needs in your community, how do we partner with you? We think it's really important for people to get vaccinated. I remember a conversation more about treatments with a community-based organization. They said, you know, we still have a lot of people in our community who don't have access to food. And so saying to them, oh, by the way, you should get your booster, doesn't really resonate. And so we said, well, how do we create a program where we get more food through food pantries and other programs, and also make it easier for people to get vaccines at the same time? So a lot of this is about partnership. It's much more effective. It's also way better in terms of dealing with the communication challenges. I always sort of said to my team, me standing up, you know, in the press room at the White House telling Americans to get vaccinated, there are like probably 5 people in Brooklyn who are going to be swayed by that. You're like, oh yeah, the Biden administration wants me to do this, I should do it. It's just not how most Americans think. And I suspect that if the premier of Ontario stood up and said, you should go get vaccinated, there might be a small number of people who might be persuaded, but ain't going to be a large number. And more importantly, it's probably not going to be a lot of the most vulnerable people who are skeptical of the way the government treats them. And so all of us have a role to play in communication, but understanding the limits of our individual roles. In many ways, I felt like I was a way more effective communicator before I went to government than once I went into government. Then at that point, I was a partisan player, even though I didn't want to be a partisan player. So those partnerships, I think, are pretty important. There's a couple more quick things on that. And the following is really more from the Mpox response than it is from COVID. So while I was at the White House, Mpox, monkeypox as it was called then, broke out in the US, Europe, Canada too. And as we built our response, we had vaccines. One of the things that we realized, again, is as vaccines started flowing out, we could see, and obviously our focus was men who have sex with men, gay men, bisexual men who have sex with men. We saw immediately large lines in Chelsea and other parts of New York for vaccines. But when those lines died away, we realized we were not getting vaccines to men of color. We were not getting vaccines in parts of the South. And again, coming back to this issue of partnership. And the other big lesson from the Mpox response was about the need for flexibility. That we initially said, well, we'll set up vaccines in HIV clinics and STD clinics and CVS and Walgreens, and you should be able to walk into any one of them and get your vaccine. Turns out a lot of people don't want to go to an HIV clinic. They don't have HIV. Turns out a lot of people who are gay, bisexual, don't want to walk into a CVS and say, I would like an Mpox vaccine. And those are the people who are really hard to reach. So what we did was we set up vaccine clinics outside of sex clubs. Let me tell you how that went, convincing the White House that we were going to set up vaccine clinics outside of sex clubs. It's a lot of resistance, The optics here were not, and what my argument basically was, do we want to be effective or do we care about optics? We care about optics. I get that. We're in a political world. And we got beaten up. The right wing went after us and had pictures of vaccine sites funded by the US government outside of sex clubs at these sort of big gatherings around Pride Month. And our feeling was, sometimes you just got to do what's going to make you effective and not worry about the politics of it too much. So, by the way, that was not part of any of the plans that we drew up. So a huge part of responding to a pandemic is about flexibility. You know, there's an old phrase about war, about like no war plan survives the first shot. The idea that like once war begins, you realize all your plans are out of date. Similarly in a pandemic, we had lots of plans of how we were going to get people vaccinated against mpox. And we quickly realized, yeah, some of them worked and a whole lot of them weren't going to work. And we had to shift. And so a really key part of responding is building in that flexibility, which can be hard for governments. Because governments are often like built on process, and you can't just all of a sudden go out and set up vaccine sites in front of a sex club. And my question was, why not? And they're like, well, who's going to do it? What are the contracting rules? It's going to take us 3 months to set up a contract. I'm like, or we can just do it. And if Congress yells at us later, we'll be yelled at. They're going to yell at us later anyway. So it does take courage, and it takes a certain willingness to deal with the fact that there are going to be consequences. Governments are not built to be flexible. It's not an anti-government statement. It's just a reality. Governments follow process. And sometimes process doesn't get you where you want, and you have to be willing to break process. And as long as you're comfortable dealing with the consequences of that, it works out okay. All right, a couple more points. Are we doing enough time? Okay, 5 more minutes, then I'll finish. A really key part of, just again, thinking about a pandemic response, and then I'll sort of talk about the future a little bit, but really key part of a pandemic response is something that was brought up, which is this idea that people get tired. And they just want to stop. And when I was tapped in early 2022, I met with the president, and I actually asked him, I said, why do you still need a COVID coordinator? Why do you still need someone to do this? The country's tired of this. And he said, well, the country may be tired, but I don't think the virus is done. He was right. Virus wasn't done. And a lot of the response is not giving up too early. We saw this with mpox, where we did a whole bunch of stuff in the fall of 22. The years all blend together. The case numbers went way, way down, and everybody declared victory and wanted to move on. And we kept the mpox team at the White House and said, there's going to be another summer. There's going to be another Pride Month. There's still a whole bunch of people unvaccinated. Like, we got to keep going. And that endurance is very hard when people want to move on. And I will talk in a minute about that desire to move on. But a large part of a response is not giving up too early. And for us, what that meant was not only just getting us through the time period and ending the national emergency, but planning for the future. And here's sort of how I thought about planning for the future for SARS-CoV-2, but with the idea this should be a model for lots of things. So first was replenishing our stockpiles. It turned out that under the Trump administration, we really had diminished and depleted all of our stockpiles. We had no gloves, no gowns, no masks. It's a heck of a way to go into a pandemic. So when I left last June, one of the key things was making sure we had hundreds of millions of high quality masks and gloves and gowns and all those things in a stockpile, and a plan to replenish it, because those things expire and you got to keep. It's hard, because telling Congress we want to spend $200 million next year to buy an additional 50 million masks, I'm making up those numbers. Congress doesn't want to fund that stuff. But being very strong that that's an important part of preparedness is really critical. Building efforts around indoor air quality. I think indoor air quality is probably like the single most underappreciated tool that we have. Doesn't require people to change their behavior. No one walks into a building and goes, it's too clean in here. Like, that's not a thing. When you turn on your tap water, hopefully you don't have to think about, is this thing polluted? Is it going to kill me? You should be able to walk into a building and not worry, am I going to get sick? Moving indoor air quality, certainly in the US, I had a conversation a little bit about this last night at dinner about Canada, but in the US is very, very hard because building codes are local. People think improving indoor air quality is expensive. We got a lot of money from Congress to make a lot of improvements in schools, and we did. But schools, like, I could not do another webinar with school superintendents because they basically were like, please stop talking to us about indoor air quality. Like, we get it. I'm like, you get it, but you're not doing it. And like, school leaders are pretty exhausted too. They've had a very hard 4 years. They've been yelled at and screamed at. They are dealing with learning loss. They're dealing with lots of challenges. So I'm very sympathetic. So stockpiles, indoor air quality, made a big investment in something called Project NextGen. These vaccines are amazing. They're not good enough. So building vaccines that are intranasal, that block spread, very hard to do, but a big investment there. Sort of modeled after Operation Warp Speed. I actually wanted to call it Warp Speed 2.0. That idea went nowhere very, very quickly. So we called it Project NextGen, kind of out of a little homage to Star Trek for those of you who are Star Trek fans. But it's an investment in mucosal vaccines and then in pan-coronavirus vaccines. And then the last but not least, I started off saying that surveillance is pretty critical. And so we've built out the National Wastewater Surveillance System in the US. You have something similar here. Wastewater is a really critical part of building surveillance against any virus, any pathogen. All right, so let me finish off just by saying, actually telling a story. I told a story last night for those of you who were at dinner, so I apologize, it's a repeat. In January of last year, so 15 months ago, we were over the winter wave. We had plotted out the ending of the national emergency. And I realized there are lots of books written about how do you respond to a pandemic, and no books that I was aware of on how do you end a pandemic. What does that even mean? It's a line from a great historian who said, pandemics end with a whimper, not with a bang. We all remember when the pandemic began. Some part of January, February, March of 2020, everybody in this room became aware that we had a global pandemic. There was a date that many of you can probably remember. If I asked all of you, when did this pandemic end? Some of you will say it's not over. Others will be like, I think it ended about 6 months ago. Some people will be like, I think it was a year ago. Pandemics fade. But to understand that better, I called up, I don't know, about 10 historians. And, the White House COVID czar seems very powerful. It turns out to be a remarkably not powerful position. But the one thing you do get is people respond to your emails, which is nice. I missed that, by the way. So I emailed a bunch of historians and asked them, would you have a conversation with me by Zoom, by phone, if you want to come in, with a very simple question, which is, how do pandemics end? And it was the most endlessly fascinating set of conversations. And I'll share one insight, which is every single one of them brought up a really interesting point, which is this idea that as pandemics begin to fade, an intense amnesia sets in, where nobody wants to talk about that pandemic. Nobody wants to engage on the pandemic. And everybody wants to put it as far behind as possible. Seem familiar at all with COVID? This is the reality of where we are. But I started off saying that we can have those views as humans, but the viruses out there and the phenomena that is leading us into an age of pandemics doesn't really care about the intense amnesia that we all feel. Obviously, you don't feel it, you're in this event. But that intense amnesia is a problem. And this is why I was so thrilled to come and spend this time with you, because I think this institute, and there are several others like it, but there are not 30 others like it. Essentially, by existing and by doing the work it's doing, is saying, we get that there's intense amnesia, we're not going to slow down. And there will come a time when people will be ready to talk about COVID and will be ready to talk about pandemic preparedness. And whenever that time comes, we've got to use the time between now and then to be as prepared as possible so we can make sure that when the next pandemic arrives, we do a much better job of protecting health and well-being and lives and livelihoods and all of that. I think the good news out of this pandemic is we've learned how to do this well. The bad news is everybody wants to sort of put it in the rearview mirror and move on. And our job is to make sure we keep those lessons alive. All right, let me stop and say thank you all for listening.